I think people abandon their basic principles. And prior to COVID, one of the things that I always preached, and I preach to my students, is that you have to be able to use your hand instruments and your ultrasonics equally as well. There are some patients where these ultrasonic devices are contraindicated, and so what are you going to do?
You know, we know you have to meet these requirements to get through the program, but you also have to know how to use your hand instruments, because when all else fails, that's what you're going to go to. If your ultrasonic breaks down in an office and you don't have those skills, what are you going to do? How are you going to treat those patients?
If you do a good job with your hand instrumentation, if you do a good job with your power instrumentation, the outcome for the patient is the same. And I think that's important for us to remember when we're putting down one method or another. We all have our preferences, but doing it right, our outcome is going to be the same.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists. This is your student-focused roundtable for the month. But before we get into the student roundtable, I want to give a huge shout out to Q Optics for their continued love and support of our dental hygiene students. You guys, if you have not looked up Q Optics yet, if you are not using loupes yet, you need to make that phone call. You need to send out that email. Every clinician should be wearing loupes. I was fortunate enough before this pandemic happened at Chicago Midwinter to be sized and measured for my loupes myself. And I love them. There are many designs, many different styles, many different options. And right now, because it's been a little bit since we've been in this pandemic, there are many manufacturers creating face shields specifically for use with loupes. And Q Optics is no exception. They have these amazing face shields designed for their loupes. So don't let the pandemic frighten you away from delivering optimal patient care by using your loupes. If you want to know more, check out qoptics.com. And thanks again to Q Optics for their continued support with our students.
Hey there, RDH students. When I think back on studying for my boards, I instantly feel that overwhelmed feeling that many of you may be experiencing right now. But don't be like me, because I personally did not attend any board reviews like the dental hygiene seminars, even though they were around back then. In fact, dental hygiene seminars has the longest track record in the board review business. They've been at it for 29 years with over 50,000 students attending and a 99.8% pass rate. Also, their speakers are educators, so they understand what your experience has been up to this point. You can learn more at dhseminars.com. And while you're there, go ahead and hit that register button. You won't regret being as prepared as possible for your national boards. So head over to dhseminars.com. Let's get into the Student Focus Roundtable. So at the beginning of the Student Focus series, this was your brainchild last year in 2019. Isn't that the year? Gosh, they're flying back.
It's the beginning of 2019. We're like, look, the students need a little bit more direction. We really value that. Like, we're so impressed you guys are even listening to this. Let's be honest.
So true. Yes.
So, let's give them something. They're taking the time to listen to us. Let's give them something that they actually could use.
And you came up with the idea of a roundtable, and we brought on different people that would talk about one particular topic. And then I kind of hijacked it for 2020 and made it a little more researchy, because that's what I do. But I hope that you guys find it helpful, because what we're aiming to do is bring on people who understand the topic and let them explain to you how they're looking at research and applying it clinically. Because what happens is we graduate with the knowledge we graduate with, and it might be a little, I don't want to say up to date. It might not be as up to date, because they had to get you graduated, right? But there's stuff on like HPV that, it's ever changing. And so we got to stay on top of that. And so we're going to bring the experts on so that we can teach you how to read the research and apply it to your patient care, so you can always be doing that up-to-date evidence-based clinical practice that we talk about so much. And we hope you enjoyed this student-focused episode.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine. Well, let's get right into this roundtable that I'm super excited about and I think is very timely and very relevant. We are going to chat about instrumentation. And I always have the best on this podcast. Let's all just be very honest, but I'm very excited about this. Today I have Lory, Lisa, and Joy, Dr. Joy. Lory, are you also a PhD?
I am not.
I mean, you're so good at instrumentation. I would just assume.
Still working on it.
You get yeah. So I'm going to let you guys introduce yourself one at a time. Lory, since you're right next to me in this little square, I'll let you go.
Okay. So my name is Lory Laughter. I'm an assistant professor and the dental hygiene program director at University of the Pacific Arthur A. Dugoni School of Dentistry. Little background. I got my bachelor's at Idaho State University, my master's at the University of California in San Francisco, and currently working on the PhD. And yeah, that's who I am.
Best of luck with that.
Absolutely.
I'm too scared. Lisa, return guest.
My name is Lisa Bahr. I am the program director at Waukesha County Technical College. I went to school there and got my dental hygiene degree from the same school that I'm now the program director of. And then I continued on to Carroll University to do my undergraduate in science and my master's in adult education and public health. So I also have kind of a passion for public health. I'm currently our level 1 facilitator at the school and our SADA advisor, as well as do some public speaking and some other things. So yeah, that's me.
Awesome. Welcome back.
Thanks.
And we have Dr. Joy.
Hello, everyone. My name is Dr. Joy Void-Holmes. I am the current program director at Fortis College, Landover. I received my initial training education at Howard University, where I received a certificate, and then did a degree completion program where I received a Bachelor of Science from the University of Maryland School of Dentistry. I do have my master's in health science with a focus in forensic investigative technology. So if you've heard me speak before, it's because I had a passion for SNAP. That is the only reason why I got that concentration. But I also have a doctor of health science with a focus in education and healthcare. So I do public speaking, mom of 4, wife of 25 years. And yeah, that's about it.
Some rock stars. I love that we're all minimum of master's degrees here. That's pretty awesome. But even with all of our education, we are going to tackle kind of the foundation of being a hygienist, and that's good instrumentation. And I find this a fascinating topic, or at least a kind of a, I don't know. I'm struggling with it because at the beginning of 2020, I was like biofilm focused, like let's do biofilm management. I'm thinking about all the ways that I'm going to prevent calculus from building up on my patients. And I'm not going to really pick up a hand instrument unless I absolutely have to. And then when I do that, I'm going to like be very strategic about it. And now like all I have in my little armamentarium post COVID, or not even post COVID pandemic, is my scaler and hand polishing. And so I think this is such a timely discussion. And I actually am on the heels of Dr. Joy's course, RDH Under One Roof, about instrumentation. I spoke with you guys for the Inspire the Future Summit about biofilm management. And so I know that all of us are like, if we were so used to doing ultrasonics prior to this, like going, oh, how do I pop off this very tenacious calculus again? Like, how does that work? What is a finger on finger? What was that advanced? I break out that book again from dental hygiene school. Do you guys have any thoughts on like what is happening right now? Like what's the pulse on the profession as far as instrumentation goes? I know that's kind of a broad question, but I'm just curious what your thoughts are.
I think people abandon their basic principles. And prior to COVID, one of the things that I always preached, and I preach to my students, is that you have to be able to use your hand instruments and your ultrasonics equally as well. There are some patients where these ultrasonic devices are contraindicated. And so what are you going to do? And it's funny because I love hand instruments. My husband says I hoard them, and I do. I'll admit it. And it took me a while to adopt to the science. And, Michelle, you just participated in my course. And, I've said there's going to come a point in time where you don't have to pick up a hand instrument, but you still need to know how to use them. So I just think hygienists I don't want to say lazy. I think that, we are really focused on, it's like production, which is not a bad thing. But I don't think that you should be compromising patient care for it. And so, in order to move faster, in order to make more money, of course, you just pick up an ultrasonic and you move on. And I think that's kind of where we headed, which was unfortunate. So thankfully for COVID, we now have that paradigm shift where we really need to start refocusing on what's important.
Lory?
Yeah, and to add to that, it scares me a little bit. So I'll admit, in my hand, a piezo for me is more effective than using a hand instrument. Luckily, I work in a school environment where I don't have to choose that very often. And our students have only learned hand instrumentation at this point.
I kind of feel the same way. I think, even when you're looking at just the students right now, we start them out pre-clinic and they only have instruments, right? And they're learning those basic skills. And then as they progress through the program, they lean more on their ultrasonic or piezo because, they have requirements, right? They're in a hurry. They want to get these patients done. They want to meet their requirements. It helps speed them along. And I think some things are lost with those hand instruments because they really do rely heavily on those ultrasonics. So I think this has kind of brought us back to the fact that these are important skills long term. We know you have to meet these requirements to get through the program, but you also have to know how to use your hand instruments because when all else fails, that's what you're going to go to. If your ultrasonic breaks down in an office and you don't have those skills, what are you going to do? How are you going to treat those patients?
Absolutely. I did want to add something. I think that for me, I didn't really learn ultrasonics in school. I knew that it existed, but the theory wasn't there. Everything that I've learned as it pertains to ultrasonics, I've learned on my own through investing in myself and taking courses. And I think that students don't understand why. Why are we using the ultrasonic? And it's not just to hurry up. That there's a method to the madness. There's actual science behind using the ultrasonic. There's actual science behind using your instruments. And I think that we have to start focusing on why we are doing what we are doing. And that's that patient-centered care plan. You don't pick up a sickle scaler for everybody because that's just what you have. And I think that's what we have really lost in this profession. It's just like, I'm just going to use one ultrasonic tip to get the job done, one sickle scaler to get the job done. And hygienists wear that as a badge of honor, and it makes me cringe. But we're not there.
Well, to piggyback on that, because it's very interesting to even think about, like, so you're saying, like, you didn't learn ultrasonics. I graduated over 15 years ago. I did learn ultrasonics. However, it was almost like choose your hand instrument over your ultrasonic because we want you to develop those skills, right? But the other thing to piggyback off of what you just said, as far as like only pick up a sickle, what I learned with as far as instruments and the choices that my school chose for me to use and have in my kit have evolved drastically, I would say. Like, even though I might have a Gracie on there, I'm a 17, 18 gal. I've also worked perio my whole career, so I've always needed, but I'm like even thinking about minis and rigids and all these things out there that never were introduced to me, not to talk about my school like poorly or anything, but that's just the nature of the beast, right? You can't have 50 instruments to be like, today I'll use. You get only so many. So I'm curious, like, when you are teaching instrumentation, like, how do you guys choose or help guide people? And then because this is a student focused, any suggestions for when they do graduate? Like, what is the best way to discover other instruments?
So I teach pre-clinic, so I'm teaching basic instrumentation. And the first thing that I tell the students is I show them the Hufridi book that's, an inch thick. And I'm like, these instruments that you're learning right now are just the basics that get you through the beginning phase of your career, that there are so many things out there that you can use to help you, and that you need to keep your mind open to all of the instruments that are out there. We do introduce our students right away to the Nevis. Those, I mean, I love the Nevis. Who doesn't love those, right? So I tell them when I'm teaching scalers, if you can use a sickle scaler, a 204S, you can use a Nevi, right? You know the basic design of the instrument, so you know how to adapt the cutting edge onto the tooth and make that instrument work. You may have to play with it a little bit, but I always tell them, don't be afraid to pick up an instrument and try it. And so we really do encourage that.
That's great. And building on that, we even tried to do a little more variety than more than one company. So their original roll-up comes with 15 instruments, and in there, we do have instruments from Hugh Freedy, we have instruments from American Eagle, we have instruments from Denmat, we have an instrument from PDT, and we show similarities and differences because some people will prefer a certain bend, some people, and so we just really enforce the idea. And I did start teaching in preclinic. I no longer teach that, but we really start with the basics, making sure, like you said, if you can adapt the last toe third of a sickle, you can adapt the last toe third of a Gracie, you can adapt the last toe third of a universal. And so it's just really making sure they have that variety. And then when we introduce them then to the advanced perio instruments, that's 8 more instruments, including the files, that aren't in that original roll-up. So I really think I didn't have that in school. I mean, I had a good variety, but I was a Columbia 13, 14 girl from forever. But I think that variety, as you said, letting them know, try something, pick up this one, see how that works for you, and not being so rigid on, this is exactly here, this is exactly here, type of instrumentation.
I agree with both of your points. And I know prior to becoming program chair, I did teach instrumentation, and we were definitely all involved in the selection process. But of course, I still didn't have the final say so. But we agreed to most points. And then to your point, Lisa, with the Nevi, when I started, and I'm like, I want to go with the Nevi, not the 204S, because from a teaching standpoint, I felt like it was easier for the student to adapt more so than that 204S. But then there was just a group of instructors who felt like, well, it's too sharp and they're slicing the tissue. And I'm like, it has nothing to do with the instrument. It has everything to do with them rolling. It's like apples and oranges. But now so what I also got to participate in what we call like their advanced seminars. And so I just took a different approach because I taught or I lecture on instruments. I brought in all of my instruments. So from Denmat, American Eagle, PDT, LM, Nordent, Premier. And I had the students just put every instrument in their hand, because the best instrument for you is the one that feels the best in your hand. And it's so interesting that, let's say out of 15 students, because at that point, they have wonderful deals for students. Students started purchasing their own instruments. And so you would have 5 that did LM, 2 that did, just a variety. Now as program chair, the one thing I did this year is that I split up my kits. So they're Explorers from LM. Some of their advanced instruments will be from LM. I've included files for their advanced kits. But for their Gracies, I actually included 3 of the Nordent Gracies, because if you look at the Nordent Gracie, it actually has that true curve on the toe, unlike most other Gracies. So, and I got faculty buy-in because I brought all of my instruments in and I let the faculty play with the instruments. And so it was just an easy sell at that point. So it's like webinars are great for instrumentation, but I think people have to be able to, and students, they have to be able to feel the instrument. So my recommendation is for faculty to reach out to these companies and get samples in the school, and you have to play with them and you have to feel them.
So one of the things that I have noticed, well, I'm also known when I teach as being kind of a snob when it comes to sharpen instruments. And so if I sit down to help a student get something out and I can't get a grab with that, I'm like, call me when they're sharp. I just like walk out of the clinic. I can't. And they're like, but I'm like, sharpen that thing. Like, I don't understand what you were trying to do here. So I would love to discuss, because there's sharpen-free instruments out there, and then and then we have the traditional instruments that we need to sharpen. How frequently should we be sharpening our instruments, especially now that we are mostly hand scaling? What's y'all's thoughts on that, Lory?
I'm going to let Lory start with that one.
I was going to say, Lory has had a lot of information on this.
Yeah.
So just by way of putting it out there, I don't like to sharpen. It is not my favorite skill. I can sharpen. If I'm in private practice, I take my own sharpen-free instruments. I don't like to deal with that. But in school, we actually put a sharpening stone, a new edge sharpening stone, so it helps the students angle. It has that tipped angle on the top. It's in every scaling kit. And they are responsible for keeping their instruments sharp throughout the entire appointment. And if they were to ask for a scale check or ask for assistance on something, and an instructor sits down to a dull instrument, not only, as you said, sharpen this and I'll come back, but that affects their final grade, which in this day and age seems to be the motivating factor, is that quarter of a point I'm going to lose for having a dull instrument on my tray. But I think and we need to transfer that then, because we want these students to be hygienists in life, and really impress upon them the point that they want to, when they do have a say in where they're working and what's in their kit, that they need to have that stone in every kit, not sharpen when I have downtime, not sharpen when I can send them out and get them back a week later, but in my opinion, being able to stop, have the skill to spend 20 seconds to sharpen an instrument so that you can finish what you're doing. And to me, even though I don't like to sharpen, that is something that we need to not lose, and as a profession, just really push for being able to sharpen at need.
I would definitely agree with that. I always tell the students, when you use a dull instrument, I'm huge in ergonomics. You are putting so much strain on your wrist and your muscles. Why would you do that? You need to work smarter, not harder. You're in that chair all day working on patients. Don't do that to yourself. You're looking out for yourself by sharpening your instruments. So take that time that you need to sharpen those instruments, and that deposit's going to come off of there a lot faster, a lot easier, and with a lot less muscle fatigue for yourself.
I definitely agree with all points. And it's interesting that you asked that question, Michelle, because I was just asked that question yesterday. How often should people really be sharpening their instruments? And the thing is, the minute there's a dull edge, and that dull edge may be different for you, different for me. It depends on the type of deposit that you're using, how you're using that instrument. But I agree that sharpening stone needs to be in that kit at all times. And here's the thing, not everybody's a good sharpener. And this is something that I had to tell one of my faculty members. The fact of the matter is, we teach it, the students will pass. Not everybody sharpens well. And I think that what we need to explain to our students is that if you know that you're not going to sharpen well, then you need to position yourself where, number one, you're in an office with someone who will keep lots of instruments on hand, or, use those sharpen-free instruments. Like Lory, I don't like to sharpen, but I can, and I have to because I teach it. But the thing is, there's so many options out there that, we're just not stuck like we were 25 years ago.
That's the truth. I've used the Gleason guide since school, and I love to sharpen only because of that. Don't ask me to freehand anything. I will destroy your instrument. But also, this is why I make a case that I want my own instrument.
Yes.
I don't want anybody else messing with my instruments. I go on mission trips with Daniel Lopez, and he's always like, oh, don't sharpen Michelle's instrument. I'm like, yeah, don't be touching my instruments, okay? I got a very specific way that I sharpen my instruments, and I don't know how you're going to be using them. I'm like, no. So I am in a new office temping, and I brought all of my own stuff. So I'm curious. Well, and I see you guys shaking your head like, yes, this is. So how do you feel about, let's say, so right now, all of our students, at least, I don't know about how this works in yours, but I would assume that we all have our own kits, right? Like each kit they purchased it, they have multiple, whatever. No?
Yeah, we
don't have that because we're in a large dental school. The school purchases all their instruments, and they're actually sterilized in a huge sterilization operation like a hospital downstairs. So they don't have their own, which does present a problem because, like you, I was lucky enough to work in the same practice most of my career, and I've always had my own instruments.
So this brings up the point then. So Lory, how does that look for your students? And if they are in an office and they go to an office where they're going to be sharing multiple kits, how do we deal with that?
So as you said, we do explain that everybody sharpens a little bit different, even though we think we teach this black and white method. Even among instructors, we tell them not to watch and we do it our own way. So we explain those differences and really push for the idea that it's good to have your own instruments. They do buy their own roll-up, so it's not instruments that aren't sterilized, but they use in SimLab on the mannequins. So they do have an idea of how they sharpen, how they want theirs to feel. So they do know in clinic when it's different. And that kind of stresses the importance, again, of having instruments your way. Again, it comes down to that doing it as they need it, not waiting for one person to take care of your dull instruments, or at least making a deal with that person before you expect that. And just really, it helps actually to bring up the importance of why, if you can arrange it, and I suggest they really do try to have your own instruments when you're practicing. Even if you purchase, like if you're going to temp, I have students who decide just to temp their entire careers. When we talk about purchasing your own, having those with you. When I temp, I have my own that I take with me, because I'm like, Michelle, don't touch my instruments. I like to mess them up my own way. So they don't have that benefit now, but we can still impress that benefit. And then by them noticing the difference between their roll up and what they're using in clinic that other students have also sharpened, that point's kind of driven home.
I think your instruments are like your best pair of high heels. You're not sharing those, or your best purse. But I often talk about, and I learned this from one of the companies that I work with, dental hygienists need to develop that construction worker mentality as it pertains to their instruments. I can relate. My husband was a general contractor, and you will purchase the basic tools typically in bulk for the workers. But what I learned is, construction workers understand that getting the best tool for the job is a direct reflection on the quality of work. So they will actually invest in the best tool themselves. And so I think for hygienists, I think they are so stuck in the mindset that if he doesn't buy it or she doesn't buy it, then I'm not going to use it. But you need, and I would always say, listen, you want me to be successful, then I need the best tool that I can to be effective and efficient for my patient. And so I think the very first time I walked into an office and said I needed new instruments, I was 22 years old. And I remember going to the dentist with like scientific articles because they were retipping the instruments. I'm like, this is why you don't retip. And I love the scale and root plane. And this is what's happening to my hand. And if you want me here and you want me to produce, this is what I have to have. And there were two other hygienists in the office. I wound up getting each of us 8 separate kits of our own, and then 2 separate scaling and root planing kits. And I'm like, is it that easy? And literally every office I went to, that is what I demanded. Like that was what I negotiated with up front, and I refuse to do it any other way. So it is an investment in yourself. And long after you leave that job, when you're having problems with your hand and your back, what are you going to do? So it's an investment in yourself. Just like your scrubs, your nice figs or Janu scrubs, you're invested in your scrubs, and you're invested into that nice bonnet or your lashes, whatever you're investing in, invest in your instruments.
I absolutely love that, because I tell the students too, same thing. When you go in for an interview, one of the questions you want to ask is, do I share instruments, or are there, enough for me in my cubicle or my operatory that I will have my own instruments? Because I said that's going to be an important factor in making a decision on where you want to take your employment and what the dentist is willing to invest in you to do your job. I've also had, we use all saddle chairs, and again, I'm huge into ergonomics. That's quite a passion. All my students, when they see me, they sit up a little straighter as I walk by. And I've had several students now that have graduated who have purchased their own saddle chair, because I'll tell them, listen, you are going to be sitting in that room, in that operatory, day after day after day. Don't wait for the dentist to buy you the saddle chair. If they're not going to invest that money in you, then you need to invest it in yourself. And so I've had several reach out to me and ask what kind we use, where they can get it. I just had one this last year reach out and say, could you please send me some information? I need to present a case to my employer so that they'll buy me a saddle chair. But I would say, just like Dr. Joy, don't be afraid to ask, because you know what happens when you ask? You might get what you asked for.
Absolutely. Yeah. And it's important to take care of what you get as well. So I know when I got my own instruments, I don't need for you to clean them, bag them, label them. I did that all on my own, because I don't expect for anybody to take care of what's mine better than me. So that's just kind of when I went above and beyond. I kept track of how often. So if you wanted me to see 8 patients a day, I had to have 8 standard setups. And if I was doing an average of 3 scaling and root planings a day, then I needed 3 separate kits. And so I would mark so that I wasn't reusing the same set of instruments. And actually, you save your practitioner or your dentist money, because you're not wearing your instruments out. So it's just a win-win all around, in my opinion.
And I would even say, keeping in the same vein of sharpening, it's seen as like something you do in downtime. I've always tried to, like you said, keep a kit or keep a sharpening stone. I always put like a quick little edge on it. Now that does pose a problem, because sometimes you got to open up that kit, right? So it just, I kind of play that sometimes, or maybe I'll even do it in front of the patient. They don't always love it. But if I'm doing scaling and root planing, sometimes I will sharpen between quads too, or get out a new kit just so that I can have nice instruments. But, the thing that's often thrown in the face of a lot of hygienists is like, oh, they're always just trying to sharpen their instruments. Oh, I see it as like, there's certainly not a need for this. And I'm like, yeah. So,
I have a perfect comeback for that.
I would love to hear it, because mine is always like, yeah, I am going to go sharpen my instruments. Say something about it.
So how about you give me brand new instruments to use? The more instruments I have, the less time I have to spend sharpening instruments. So that's what I say. If you're seeing 8 patients a day, maybe, and they're 8 just like standard recare, not a lot of deposit, then maybe you should have 10 kits, because the chances of you, and you have a good ultrasonic tip, so the chances of you wearing that instrument out is slim to none. So absolutely, if you want to help me out and help my cause, convince the employer to get me more of what I need.
That was also our argument for going sharpen-free. So in the practice where I worked, the last 6 years I worked there, there's 3 hygienists. We all had our own set of sharpen-free instruments. We had a stone for those, what we called unicorns. There are many micro after 5s, but we found that we actually saved our employer money by not sharpening, by having our own kits that we took care of, because we all scaled differently. With the sharpen-free, we all had 8 setups. We had the perio setup separate. And we actually could show and track that we saved money by having sharp instruments all the time that were only used by us. We actually even had a set for temps, so they didn't have to use old other instruments. They had a nice set of their own, and it actually, like I said, came out saving money. So that you can make an argument either way for that, but it saves time, and it actually saves money to have sharp instruments. So either I'm going to sharpen and it's going to make noise, or I'm going to have sharpen-free instruments, but it's going to happen.
And I was always like, with my doctors who did surgery, I was like, well, next time you ask me to change that 15 blade, I'm going to tell you to, why you need a sharp blade. I don't get it. What's the problem?
Yeah. Right. Or use that burr 3 more times.
Yeah. What you need a sharp burr for? I don't get it. Why? What's the problem?
Or how many times have you gone into temp somewhere and you pick up what you think is a scaler and it's really a Gracie?
That is how I learned how to get really proficient with my Gracie 1314 as a temp. The only sharp instrument in the kit was that Gracie 1314, because they wore those sickles out. And I understood the importance of a sharp cutting edge. And so I learned to use my Gracie 1314 like you would not believe. So it was funny how that happened, but you're right. And so these hybrid models now, where you have your dual Gracies or your double Gracies, I'm like, they owe these hygienists checks, because they had been creating these instruments long ago.
So, Lory, I believe you have some science that you would like to share. And, originally this roundtable was created to discuss articles and evidence-based research and how we discern what is good research and also what is clinically applicable to us. So I'm very interested to see what you brought to us today.
So, and thank you for that. I really just looked up a couple of things, because I just said what we hear going on. And one of the things I hear going on is that hand instruments is not as effective, and I think it depends on whose hands it is. But if the Journal of Clinical Periodontology in March of 2004 had an article, and this is actually based on showing whether or not mechanical power-driven instruments were as effective as hand scaling and sonic scaling. So I know there's not much sonic scaling going on in the world anymore. But the conclusion was there really is no difference. So you can be effective with whatever you're trying to be effective with. So based on outcomes, this did not look at, I know there's studies showing differences in root roughness, and obviously the ultrasonics and the piezo's win out on that over hand instrumentation when you look at microns. But according to this, and as far as outcomes, pocket depth reduction, and inflammation markers, there is no difference. If you do a good job with your hand instrumentation, if you do a good job with your power instrumentation, the outcome for the patient is the same. And I think that's important for us to remember when we're putting down one method or another. We all have our preferences, but doing it right, our outcome is going to be the same.
And so we're really focusing on like the root and also hard deposit, not necessarily biofilm, right?
But this did show that. It was an outcome-based study, but it showed they removed calculus. They specifically said, I'm looking at the thing right now, it was specifically for bleeding on probing, pocket depths, attachments, obviously, and hard deposit removal. So they did actually look at calculus removal as well. although the study, again, was on outcomes.
Did that study, though, include the biofilm? And that's one thing I talked about. We have to understand why we're doing what it is that we're doing.
Let me go back and read exactly here. Hang on a second. Moderate to severe periodontitis, plaque index, bleeding on probing pocket depth, attachment level, number of moderate and deep pockets, number of what they call hard organic deposits, which I'm assuming is calculus. So, it didn't directly address biofilm. But again, I'm assuming if the outcomes are reduction in pocket depth and in reduction in inflammation and increase in attachment, then we're obviously addressing biofilm. It may come from oral hygiene education. I don't know where the biofilm reduction in the study is coming from. Again, that's a limitation. I just was looking at the argument that hand instrumentation does not provide as good treatment as using our ultrasonic instruments. And I agree, for biofilm removal, there is no comparison. But if we look at doing the best we can with what we have, it's good to know that by the research, our outcomes will be similar.
Absolutely. I've actually referenced that study in some of my slides. So what works best is what you can use the best. And for some people, it is their hand instruments. And for some people, it is their ultrasonic stuff.
It makes the argument. So one of the discussions that I have with lasers, I can't use lasers. Well, thank you, South Carolina. But I learn from people who can use lasers, and my understanding time and time again, it's more about like whose hand it's in. Do you understand your machine? Do you understand how it works? Because some people who are like, lasers don't work, most of the time don't know how to work their machine or use it in the way that it was meant to use, or as a supplement tool during whatever they're doing. And I think that goes to say this be the same for our ultrasonics. People shy away from piezo's a lot of times because they only learned magnetostrictive. They shy away. I know, and I love my piezo. Like, whew.
They work equally as effective, but they work equal. They are both effective. It just, whose hand is it in?
Whose hand is it in? And I will say my hand struggled in the beginning because I was very used to a magnetostrictive. And now for whatever reason, I use both, to be very frank. Like I have both of them in my op, which I love. But then going back to instruments, like if they can't manage to change their technique for a sickle and they're doing gingivectomies on the reg, then maybe we need to let's look at some other options out there. Like, so it all comes back to like, whose hand is it in? How does it feel? Do you have good ergonomics with it? Are you capable? And if you're not capable.
And I think it's important when we read research, I think it's also important that you understand what the target is. So the target of this research was, does it show improvements in pocket depth, attachment level? And the same study, if your target is, does it cause root roughness? Then we're going to have other outcomes. Is it affecting biofilm? We're probably going to have other outcomes. So we really need to look at the target. And for me, the target of this was just that you can be effective with all three.
I always tell the students, the instrument is only as effective as the clinician. So if you're not able to use your instrument properly, you will not be effective.
I agree. I'm finding that's the problem with a lot of the sharpen-free instruments. Hygienists don't want to change the way that they scale. And you cannot use a sharpen-free instrument.
And that's me. That's me, 100%.
You cannot use a sharpen-free instrument like you use a stainless steel instrument. And it's like, I don't know why hygienists fight the science. We say we practice evidence-based care, but we are selective because we don't apply it to our hand instrumentation skills. It's just beyond me. It is absolutely beyond me.
I think it's habit. I mean, have you ever heard someone say, well, we didn't learn that in school, right? I tell the students, I don't ever want you to graduate from here and say those words, because we teach you basics, but you have to go out into the world and learn more. I tell them you're like a baby. When you leave here, you've just learned to walk, right? We got you through rolling over, sitting up, crawling. Now we got you to the point where you can walk. But once you get out there, you're going to learn to run. You need to keep your mind open and find out what's out there and learn what else you can use when you're out there.
And I got my sharpen-free without any training. So I struggled in the beginning with that. And then, I mean, I heard shaving stroke, but it really didn't.
You didn't hear it.
It did not comprehend to my muscle motor patterns. And so it took me a hot second. And also I was in a particular outreach program where ultrasonic tips were worn out. And so I was doing so much hand scaling that shaving stroke just was not working in my favor at all. So, but it's more about like you said, the practice you're in, like, what are you doing? When I go on mission trips, like I'm popping off chunks of calculus. There's not an ultrasonic in sight. I'm probably not going to choose to bring my sharpen-free instruments. But when I'm doing like biofilm management and I'm knocking it out with the air powder procedures and then following it up with some kind of ultrasonic and then just hitting the high spots, I mean, I think that's when sharpen-free is amazing.
Sharpen-free is more than just about, in my opinion, especially with certain brands, it's more than just about the stroke. It's also about the ergonomics as well. It's about that handle. And I think that we also need to focus on that as well, that these handles, especially with sharpen-free, they're designed so that you don't apply as much force, as much pinch force. So that's something else that, I don't think clinicians really consider. Like, do you really consider the handle that you're putting in your hand? You complain about carpal tunnel and you complain about pinching. And so here it is, we give you something and you still complain about it. Not you, Michelle. I'm just saying in general.
And I think too, again, there we got to remember the target, because where I practiced, the dentist actually liked the sharpen-free Barnhard 5.6 for removing cement when he did crown seats. Totally inappropriate. He went through an instrument about every 4 months. He did not care. He loved it. Again, he liked the handle. He liked the fact that he could take that off of there in a couple of shaving strokes and not have to worry about it and knew it was gone. And that was his choice. He was never allowed to touch a hygiene instrument because then it was horrible. But again, his target was, I want to make sure I have smooth margins on my crown seats. And he felt comfortable putting his investment in an instrument that he liked in his hand, that he felt did that for him. And if replacing every 4 months was the price he paid, that's the price he paid. So targets, we got it. What's our target?
Such a good point. I think also I go into a lot of offices now and I'm finding old, skinny instruments.
Oh, Michelle, I can't even believe how well you set me up for my article.
From the 90s.
Oh, yeah.
So my article is The Effects of Instrument Handle Design on Dental Hygienists' Forearm Muscle Activity During Scaling. So fits right into this. So this study, who Jessica Sudbeck was involved in, and this study talks about not only the weight, but the diameter of the instrument. And they did this study and they had a 16-gram instrument with a 12.7 millimeter diameter, various diameters and sizes. And what they found was that the instrument size did not have as much effect as the weight, which I think most of us know. That's why we've transitioned from these heavy instruments to the lighter instruments and have more success with them, less ergonomic trouble with our hands and forearms. But this study definitely confirmed that the lighter instruments are better ergonomically for us. The handle design in this study was not as important as the weight.
Well, thank you very much for that. In your webinar that you did, Dr. Joy, the other day, you were talking about root planing and how we don't really do that as much anymore. Like,
Shouldn't be doing it at all.
We should not be doing it. And I think I came out of hygiene school on the cusp of that, well, at least in where I was locally.
Classy, smooth.
Yeah, nice and smooth. And I worked in a perio practice. So there were multiple times where, I was taught very early on to dig into it and slide on down. Like, you clean that thing. And when we would flap those patients back and I'd get in there and I'm like, oh, oopsie daisy. Did you want cementum with your tooth? I don't know, maybe not. No, not so much anymore. So I think too, when you bring up that pinch and how much pressure, we really shouldn't be doing that anymore either. And then we bring in the weight and the diameter of the instruments and how important ergonomics are.
Absolutely. Again, I go back to the science. The science has been there. I just feel like it'll take another 20 years before it sinks in. And it's amazing that I've, told some experienced clinicians, some people who are, really VIPs in this dental hygiene game. And I'm like, there'll be a point in time when you don't have to pick up your hand instrument on certain patients. They're like, absolutely not. I don't see it. And I'm like, well, science tells us that you never really do remove all of the deposit. I don't believe that. And I'm like, okay, but you just gave a lecture on the importance of science and evidence-based care. And I'm presenting the science to you. So it's just a shift. Like I said, I love my hand instruments. And it took me a while to say, what do you mean what do you mean that I could have a patient and if I just use the right tips and an air polisher and a laser that I don't have to pick up my hand instrument? But yeah, it's possible. And I really think it starts in the schools. We have a lot of educators, a lot of, seasoned educators that have been practicing for 20, 25, 30 years. And so we can't get the educators to change that.
I think beyond that, Dr. Joy, we've got to get the exams to change their mindset, because we'd love to teach, don't blanch your fingers, don't hyperextend your fingers, keep your joints straight or in a C shape. And then they're graded and given a license on how much pressure they can apply to remove deposits in a one-time exam from a quadrant of a mouth. If we can't change what the outcome of our exam process is, we're never going to be able to change the outcome of education. They're not being graded on biofilm. They're not being graded on how well they can treat a case. They're not being graded on outcomes or even their understanding of the science of what makes a healthy mouth. And if we're not testing our students on that, but rather we're testing them on how fast can you remove these 12 deposits, how are we going to expect? We can't really. I would love to teach differently. Honestly, I went in with the idea that I was getting rid of blanched fingers. I was getting rid of extra lateral pressure, and then realized I would have students who couldn't pass tests that were based on lateral pressure. The test is not based on, this is my ideal, and sorry if I'm rambling here. My idea of a great test for licensure would be, take me through a case that you did. Where did this case start? What was your reevaluation? Did you change at your reevaluation? Did you achieve health? And even if the answer is no, why or why not? To me, that shows a hygienist and what a hygienist needs to know. Some can't test everything they need to know. Better than, can you remove these 12 deposits? I don't care how you do it, just get them off.
I think both need to be included in, I'm an examiner, so I see it on both ends. I see it three different ways, actually. I see it from the student perspective because I was senior cohort manager. I run mock boards at my school. I see it from the instructor perspective because you're right. It's hard when you want to teach them this way, but you also have to teach them to test, if you will. And then I see it from an examiner standpoint. And as an examiner, some schools really nail it. Like they really hit the mark. And then other schools, you're like, wow. To me, we have the power to save a life, but we have the same power to take a life. We are using sharp metal. Our instruments are medical devices. That's exactly what they are. And so I get that no other health profession has to sit for a patient-based exam. I'll use nursing as an example, but they also go on rounds through the hospital. That's not something that we're able to do for dental hygiene. So there has to be some type of third-party system to evaluate. So even with the mannequin exam, I'm just like, whoa, oh my God. We don't really see the damage that these students have been doing to the root surface until this mannequin exam came along. So I agree with you, Lory. We do need to be testing for outcomes, but because what we do matters, like we can cause just as much damage with those instruments, there has to be a way to assess that as well. Now, how we do that, that's the $1 million question.
Yeah.
Yeah.
No, we agree on that. I agree on that. We need to have maybe multiple testing bases.
Yeah.
But to just base it on removing calculus, I think is hindering our education.
So do you think, I know, and I'm not sure, are you in California?
I'm in California.
Okay, so I know for the Eastern region, we do use the CDCA, and they do have like the patient-based exam, and then they have the computer-simulated exam, which deals a lot with case studies. Do you think what you're talking about, that outcomes-based assessment, could be incorporated more into that clinical-based assessment?
As far as I know, we don't have that option. We have REBS, we have credits, we have ADEC. So yes, something that included, I'm not saying don't test on whether or not a student can remove calculus. That wasn't my point at all. Sorry.
Oh, no, I got what you were saying.
But I think if that's the only focus, we're doing disservice. So yes, some kind of, we have national boards too, but that's more the basic stuff. I think we need national boards. Don't get me wrong. I think we need some kind of clinical evaluation. And what you just described to me makes a lot more sense. So the actual tactile, do this on a patient or a mannequin. I think a mannequin's actually a great idea in many cases, like you said, because you can see the damage. And then this simulation, do you know do you know why this outcome? Do you know what brought about the outcome? Can you even evaluate what an outcome might be?
Exactly.
Do you know what an outcome is? I think we would graduate a whole different level And we teach it. Don't get me wrong. I'm not putting down education. We teach it. We do. But then you have to shift your focus again to reps coming. Can you get that calculus off? We could keep more focus on those things to me that really matter. The biofilm, the outcomes, the removing, but why are you removing it? If we had something like,
how do you prevent it from building up? All of that.
I know how we do it. I know exactly how we can do this. We become autonomous and create our own exam.
Amen.
bingo.
And I love that we're having this conversation. Actually, Andrew and I battle out on this topic all the time because he's also an examiner and being a faculty member.
Andrew, my love.
I know and you make great points. He makes great. I think we're all making great points, and it's not just one way or the other. It's not very black and white. There needs to be a change. But I also think, and this is to Andrew's point, often is the calibration of each school is very different.
Oh, yeah.
And that is where it becomes, that's where you need that third party. I know,
Yes.
the shutter, Lory, the shutter. Yes.
Yes.
And that's where you need that third party. And, for a very long time, I had the perspective of I thought as a school, we did a very good job to teach and help them pass their boards. So we were probably on the better end of that. So I don't have the perspective of seeing the worst of the worst and graduating some questionable clinicians out there. But I do agree, the outcome based, God, we need it desperately, because if we are following the science, as we say repeatedly over and over on this podcast, we are getting to the point where we can put our scalars down and really prevent the disease. How do we create homeostasis? How do we help our patients understand their level of disease and their accountability and really find things that work for them? And I mean, I was one of those people that was like, you want me to put my scalar down? What? I get a heroin dopamine release when I pop that calculus off. And you're going to tell me not to pick up a scalar? Excuse me. And it was a salesperson that told me, and I was like, that's super adorable. Look at you, sales rep. You trying to tell a hygienist I'm going to scale teeth?
It's hard. I have an instrument addiction. So it's just I'm always going to use my babies. They're my babies and they're well taken care of. But I would be a hypocrite if I don't follow the science.
So true.
We call ourselves prevention specialists. I mean, if we're not willing to focus some time on prevention, we need to stop calling ourselves that.
Including prevention for us. Exactly.
The thing you can say is you can always help them clean up what's there. But can we prevent them from getting that there? Can we educate our patients? Can we share our knowledge with that information to help that patient prevent that disease? Because we can go in and clean it up, but can we keep it from happening?
Nail on the head. Thank you. So my final question as we kind of end this wonderful podcast, God, this is where Andrew is always like, I would go on for 3 hours with you guys if I didn't have Andrew chirping in the back of my head, tighten it up, Michelle. So I want to know each one of your favorite advanced fulcrums.
So it depends on my outcome. What am I trying to achieve?
Oh,
you like that, don't you, Lory?
All right.
But it's true that it does depend. I would say I love my extra oral. I mean, and I don't even think that's an advanced fulcrum. That's another story for another day, because
that's just normal.
To me, that's a standard fulcrum, but I love my finger on finger. And I love it when people come in with that, old cement, or, they've had brackets on forever and they're like, we've tried to pop it off and we've tried to, and I'm like, yeah, these hands were made for scaling. And I take that finger on finger and I dry that surface and I pop it right off with that finger on finger. Like I'm the queen of lateral pressure, which is not a good thing, but.
Joy, I love that one because I do that all the time. And sometimes I have to say to the students, okay, look away for a second, because that's not what
You're not ready for this,
right?
Right.
You're not ready for this.
And I will say that this is something when you get farther along, you can do.
Yes, but I love it. I love it. I like sitting at 3 and 5 o'clock, because when you were in school, and this is where I love Anna Patterson, because she just, you were taught in school, how dare you go past 12 o'clock. And I think this was back in 2015 or 16. I went to one of her courses and it was just like, this is just something that you do. It's not even considered advanced. So I started, you mean to tell me I can have direct vision for the link?
Oh, get on over on this side of the patient.
Let me scoot. And it's just like, I battle with some of my own instructors to say, listen, people, we don't teach. I remember I had to sit with my thighs parallel to the floor, and it's just not like that anymore.
Our back suffered for so many years.
It's just, we could go on and on and on about this. Like, I wish I could be Lisa's student, and I wish I could be Lory's student, because I love learning, love learning. But yeah, so many things that I think that they're considering it advanced, and it shouldn't be advanced anymore.
I do admit I'm an intraoral fulcrum snob. I will extraoral fulcrum when I have to. And by way of full disclosure, I'm writing an instrumentation book, so I love your idea of where to sit, because in this book, we're getting rid of our 8, 9, 10, 11 stuff. But finger on finger, I really like, but I've kind of developed my own little fulcrum that works well on the maxillaries when I'm trying to do the facial of like 14, 15, 2 or 3. I like to fulcrum on the opposite side of the tooth. So I will fulcrum on the tooth I'm on almost on the opposite side. And I've never seen a name for it. And in school, I got in trouble for it. But I'll show students the same kind of fulcrum now. Like you said, that lateral pressure, it gives you so much, because you can pull towards yourself rather than trying to push. You've got a fulcrum here, and I can't show you. You have a fulcrum on one side, and you're squeezing, you're pushing together, not trying to push against it. So I don't know, I have a name for it, but I like that.
So I teach that as a standard intraoral fulcrum.
I do as well.
Yeah.
Wow, this is news to me. I can't wait to go back to clinic. I might even get a type.
You can call it a tooth-to-tooth fulcrum, because you're on the tooth on one side and you're on the tooth on the other side. So it could be tooth. Yep.
That's the first thing I do when a student's having trouble maintaining a fulcrum on a tooth. I'm like, okay, well, let's hook that on the lingual and see what happens. And they're like, oh.
Changes everything.
And if you move to 3 o'clock, you can hook it on the facial through the lingual.
Exactly.
I wonder if I'd do it. I can't wait. I cannot wait. I'm gonna have to.
But these are standard things, and I have short fingers, so my finger has always gone directly behind the tooth that I've been working on. So that's interesting. So I just assumed that everybody taught that way, but it's glad you mentioned that, Lory. So now I have to say,
yeah.
If you go by the book, it doesn't really exist. If you go by reality, we all do it. So you might as well teach it.
I'm a fan of finger assisted, where I put the pressure on the instrument as I scale down, or with the stroke. That's my go-to, especially if I'm working on the opposite. Like if I'm left, I'm a righty. So if I'm working on, 14, 15, something like that, I'm a big fan of that. And students are like, what? It's like, look away. You're not ready for this. You're not ready.
But with that being said, if these are things that are helping us, why aren't we sharing these? Why aren't we teaching these students some of these things?
I would hope it's being taught later on. I teach it in the last semester when I get the students that are like pretty much on their way out. They're about to, I'm like, all right, y'all, we gonna get them class 4s. Bring them in now. We're ready for them. And that's when I teach them. You were saying like, you don't like pre-clinic, or you don't teach pre-clinic anymore. When they ask me to teach pre-clinic, I'm like, what do I have to?
That's where I thrive. See, and I think...
this is so good. You take the pre-clinics.
So I've taught pre-clinic and managed senior clinics at the same time. So I've seen what it looks like in the beginning, and I've seen what it looks like at the end. And I think, but Michelle, I admire you for saying that that's just not where I'm best at. And I think that you really have to have people who are very patient in those pre-clinics. And one thing my students said to me is that you can walk in and you automatically can see what's wrong. And I think for certain people, they're like, well, fix this and fix that and fix that. And I'm like, just scoot the chair to the left, just 3 inches, and everything falls into place. But you have to be patient enough to just assess. And I think that when you're so advanced, you forget those foundational skills. Like the pivot is a real thing. It's a real thing.
Because you're just doing it. You don't even think about those, like what is actually making you successful in that stroke. You're just doing it.
Exactly. And for students, it's like, we teach them how to roll, and we teach them how to fulcrum, and we teach them how to wrist rock and all of that. And then we say, okay, it's time to put all of those concepts together. and I can physically, it's like I don't hear them, but I hear them talking to themselves, and I see the hand, and I'm like, yeah, it's not coming together. So I'm like, just slow down. And it's just like, I record them. I love my cell phone, just recording them, recording me. And I'm like, okay, what do you see? What looks good? We always start with something positive, what looks good, and what do we need to improve on? Not like, oh my God, everything sucks. Like Michelle, I so see you saying that, like, oh my God.
I think too, it's important to have a starting point. So when my student is really struggling, we go back to the very, where is your light? Where's your chair? Where are you seated? Where's your hand? What's your grasp? So in pre-clinic, and I didn't think I was going to love pre-clinic, and I honestly did. I miss it a little. I do enough sim lab now to be okay. But you're right. It's a whole different, there's no gray area. Everything is what it is on the line. And then you get them a little further along, and we have to remember to try to keep those principles while letting them go off on their own way of doing things. But when you talk about fulcrums too, I remember we can't all, like Joy was saying, they can't all be advanced, because I had a student the first year I taught with very large hands. He was a larger gentleman with very large hands.
Can you say that again? Can you say that again? Can you say that again, Lory, and say
the people in the back?
Say it really loud. Say it loud.
It's real loud. There was no teaching intraoral fulcrums to this man. I don't want to be gender specific. He happened to be male, but to get his hands inside somebody's mouth was, unless it was an anterior, was really a struggle. But finger assisted worked well. Finger on finger worked well for those areas we really needed some leverage on. But we got to quit calling them advanced. We've got a fulcrum for effect and fulcrum for where we need to be.
Exactly.
I think that's really important, because faculty gets set in their ways sometimes, and they're trying to correct, make them do something that's not working for them. And I think we need, as faculty, to understand and have that flexibility to say, okay, your fingers are bigger. Here are some options for you to make this work for you. Instead of being so rigid that this is the way we're supposed to do it, you need to do it this way.
Thank you. So one thing I definitely teach, the book says, well, where should your fulcrum be? And they're like 2 to 3 teeth away. And I'm like, nope, as close to the working area as possible. So for my female student who was 6'3" with fingers that were probably twice my size, we're working on number 3. Her fulcrum may have been on number 7. That was as close to the working area as possible. So yeah, I had someone try to shove, like I had a male student, and was like, I've seen dentists use an intraoral fulcrum. Well, that's probably why they can't scale as well as we do, because it's just not. It doesn't make sense to waste time trying to force somebody to do something that they're not going to do when you walk away. So
good. Thank you guys so much for coming on with all of your expertise. I mean, I find some of the best. I do. I'm so lucky. I'm so grateful for you guys spreading the message and talking about instrumentation in a time where we're all very, very involved in hand instrumentation these days. And so I think it's a very important topic. And I would just like, as my final message to everybody listening, please don't let school be the last instrumentation class you take. Please, for the love of all teeth that don't have root damage, please. all good debridement, all clean root surfaces. Please don't let that be the last time that you take an instrumentation class. And I think there's a lot of shame that comes to a hygienist that needs, quote unquote, needs to go take an instrumentation course. I think we all need it, and we should have it, because there's things that we forget, and there's little bad behaviors that we develop but don't even realize it. I think an instrumentation course should be just like a standard CE that we all take.
Should be mandatory for licensure. Just like CPR.
Yeah.
Agreed.
Well, I would love for you guys to tell us if anybody has any questions, or you have any information where they can find more info and resources from you. Where can they do that?
For me, drjoyrdh.com. Email me at info@drjoyrdh.com. All social media, Dr. Joy RDH, and I actually do teach instrumentation courses. For those of you who are ashamed because you feel like you need to take an instrumentation course, you are why I created these courses.
Nice.
Mine's also my name, LoryLaughter.com. It's Lory with a Y, Lory. You can email me from there as well. If you forget that, it's the same thing at AOL, because I'm old and I like it. I also teach instrumentation courses. I'd love to teach one with Dr. Joy someday. I think we could maybe reach out there and
Yes.
start changing the world.
That's right. Lory, I'm going to give you a call.
Yeah. And you can reach me at Bahr, it's BAHR, at wctc.edu. And as well, I teach some courses on specializing in flipping the classroom and student feedback and some other things. So, yeah.
I've taken Lisa's course and I've had Lisa teach my own faculty. So if you are in need of a course for your faculty, reach out to Lisa.
Thanks.
That's amazing. Well, thank you so very much again. So grateful and honored to have you all on this podcast.
Thank you.
Thank you, Michelle.
We hope you guys enjoyed this roundtable. Thank you to our guests for bringing all their advice and their research that they found for us. And again, follow us on Instagram, follow us on Facebook. You can always go to our website at tale2hygienist.com. We would love your feedback. And don't forget to share this episode and rate and review us on any of your listening apps.
Thanks, everyone.
Bye, y'all.